Chapter 36 is focusing on the concept of psychosis. The word psychosis originates from the Greek word psyche, that means the soul, and osis, meaning an abnormal condition. The term was we started to use this term for the first time in 1845, and the term psychosis was also used to distinguish disorders of the mind from neurosis, which were thought to affect just the nervous system. Psychosis, therefore, became the new term for so-called madness, and as such, much debate started about how many forms of this new disease actually existed. Psychotic disorders are a group of serious illnesses that affect the mind. They make it hard for someone to think clearly, make good judgments, respond emotionally, communicate effectively, and understand reality, and as a result of that, able to behave appropriately. Psychotic disorders are characterized by a totally disconnection from reality. Psychosis may occur as a result of a psychiatric illness, like schizophrenia. In other instances, it may be caused by a health condition, by medication, or by drug use. Some possible symptoms will include delusions, hallucination, talking incoherently, and agitation. And the current thinking is that although around up to 3% of the population will meet diagnostic criteria for a psychotic disorder, in fact, there is a significantly larger and a variable number that will experience at least one psychotic symptom in their lifetime. In other words, psychosis is a common feature to many psychiatric, neuropsychiatric, neurologic, neurodevelopmental, and medical conditions. It is the hallmark feature of schizophrenia spectrum and also is encountered in other psychotic disorders. A co-occurring aspect to many mood and substance use disorders, as well as is found as a challenging symptom to many neurologic and medical conditions. Psychosis can result in high levels of distress for both the patients and the loved ones, which is why it has become a primary target of treatment for medical professionals. Please pause this presentation in order to review the goals for this concept presentation. As usual, we'll start by trying to define what psychosis is. And the Diagnostic and Statistical Manual of Mental Disorder, DSM, which is the handbook used by healthcare professionals in the United States and much of the world as the authoritative guide to the diagnosis of mental disorder, characterizes disorders as psychotic or on the schizophrenia spectrum if they involve hallucinations, delusions, disorganized thinking, grossly disorganized motor behavior, or negative symptoms. I need here to define what a negative symptom is, and a negative symptom includes a decrease in behavior. As an example, apathy, lack of social life, anhedonia, the inability to feel pleasure, emotional blunting, lack of motivation, or incoherent speech. We will look now into the scope and the categories of the concept of psychosis. The scope of psychosis exists along a continuum that ranges from absence of psychosis to severe psychosis. And you can see that is represented on this spectrum as from the green to the right to the red side of the spectrum. Between the extremes, there exists a line of demarcation where the symptoms are not of a sufficient intensity or duration or degree of functional impairment to be considered clinically significant. Symptoms that exist below this threshold are consequently referred to as subclinical, like other health states. Psychosis is not static. On the contrary, psychosis is best conceptualized in the form of a distinct episode of clinically significant symptoms. The frequency of psychotic episodes is contingent upon the etiology of psychosis. can be acute in onset and relatively short in duration, as can be seen with a delirium or substance-induced psychotic episode. Likewise, psychosis can be chronic, as can be seen with schizophrenia or psychoaffective disorders. What will be the normal physiological process for psychosis? So the primary psychotic disorders are considered neurodevelopmental abnormalities, and they are believed to develop in utero. Although many times the manifestation of psychotic symptoms and the full-blown illness correlate with epigenetic or environmental factors as substance abuse or stress or immigration, infection, a postpartum period, or other medical causes. By now, we have significant evidence for genetic risk factors in the pathogenesis of psychotic disorders. Most strongly linked to the pathophysiology of psychotic disorders is the neurotransmitter dopamine. Remember this one for psychosis: dopamine. The positive symptoms, delusions, hallucination, and repetitive movements that are hard to control, all seen in psychotic disorders, are all believed to be caused by an excess of dopamine in the mesolimbic tract. Glutamate, which is an excitatory neurotransmitter, is also implicated. Multiple studies have found a decreased function of the N-methyl D-aspartate and the NMDA glutamate receptor. Psychosis can manifest from a wide range of etiologies and can be categorized as either primary or secondary in origin. In other words, psychosis, which is primary, has a pure psychiatric etiology, as can be seen in schizophrenia, schizoaffective disorders, and in some instances, other psychiatric illnesses. The secondary psychosis has an organic etiology. So, to summarize this for you, primary psychosis is a mental condition, totally psychiatric etiology, while the secondary one developed as a result of an organic condition. And it can be seen, the secondary one, in acute substance intoxication, delirium, or dementia. Primary and secondary forms of psychosis are not mutually exclusive, however. Not only do they sometimes coexist, but also in some instances they may potentiate each other. Absent the primary source of psychosis, individuals that manifest secondary psychosis have greater potential for recovery from a psychotic episode without clinically significant side effects. Those with a primary etiology of psychosis are more likely to manifest subsequent episodes of psychosis due to the predisposing genomic variation and subsequent neural circuit compromises. We'll discuss now and we'll see what will be some consequences of this condition. So within the schizophrenia spectrum and other psychotic disorders classification, the psychosis is the principal symptom of interest. Clinical disorder in this category will include delusional disorders, brief psychotic disorders, schizophreniform disorders, schizophrenia, schizoaffective disorders, and catatonia. As a primary etiology of psychosis, the schizophrenia spectrum and other psychotic disorders as well will reflect a greater potential for long-term disability due to their etiology. Schizophrenia is a diagnostic of exclusion, and that means that any other possible, typically medical, explanations must be ruled out before we say that the patient has schizophrenia. Regardless of the underlying cause, any untreated psychosis is associated with poor outcomes. Untreated psychosis reflects a persisting neurotoxic state that potentially has the option to compromise and deteriorate all the neural pathways over time. The idea that early treatment leads to better outcomes is nowadays the standard. And from cancer to coronaries, we found that detecting early a disease will offer not only detecting but also treating it will offer better prognosis for the client. The same has been found in treatment of primary psychosis. So you can look on this slide and read what happens, what will be the psychosocial consequences, and you can see that they can be devastating both for the individual and for their loved ones, including on the large range of interactions, the entire society. Risk factors. We can say by now that all individuals are potentially susceptible to psychosis regardless of their age or gender or race or ethnicity. There are no conclusive factors for psychosis in general. However, family history for psychosis, some past psychotic episodes, substance use, stress intolerance, ineffective coping skill, or pre-existing psychiatric illness are all common variables among those who manifest psychosis. And a large research exists already on risk factors associated with schizophrenia. And for this reason, the discussion of risk factor is presenting from this perspective. So risk factor determination reflects both genetic and environmental influences. Early impaired social functioning appears to be a risk factor for psychosis. Schultz and his friends identified that children with a premorbid IQ in the learning disability range will demonstrate statistically significant and increased risk for schizophrenia. Another researcher, Werner, determined that lower individual and community level socioeconomic status at the time of birth will be associated with an increased risk for schizophrenia. It is very interesting to observe that prevalence of schizophrenia has also been correlated with population density in cities with population exceeding 1 million. And those were the general population risk factors. Let's look now into what will be some individual risk factors, and those will fall into 4 areas. If you remember, they are very similar to those for anxiety. Temperament. Those with a pre-existing personality disorder and asocial individuals have a higher risk. Environmental. The environmental risk factors for schizophrenia spectrum disorder can be clustered temporally by early life, let's say obstetric complication or season of birth or prenatal versus postnatal infections, maternal nutrition, and maternal stress. They can be related to childhood, um, adverse child rearing, child abuse, or head injury during childhood, and later life. That would include drug abuse, migration, ethnicity, urbanization, social adversity, and some stressful life events. When we are looking at the genetic factors, the research suggests that schizophrenia currently has the strongest demonstrated genetic linkage among the known psychiatric disorders. Gene variants increase the relative risk for the development of psychosis through the subsequent degradation of key neural pathways in the brain over time. The physiological risk factor. Some research establishes that decreased cortical gray matter may also be associated with an increased risk for development of schizophrenia spectrum disorders throughout the lifespan of the individual. How do we assess a client with psychosis? The assessment for psychosis will require a systematic collection of a history, physical assessment, mental status examination, and, of course, diagnostic testing. As mentioned before, psychosis is associated with progressively compromised neural circuits, and for this reason, the symptoms are both progressive and they will evolve over time. Many subclinical symptoms will occur before the patient is overtly psychotic. Thus, early recognition requires a very critical eye. To a casual observer, individuals with subclinical symptoms of psychosis may appear odd. They may be perceived as socially awkward or easily distracted. For a professional or expert nurse, they will be able to perceive subtle signs of psychosis, such as hallucination and negative symptoms, whereas the novice or advanced beginner is usually only sensitized to the more overt signs of psychosis, such as delusions or disorganized behavior. Always a thorough history is very important. The patient not always may be able to answer questions, so we need to rely on family or friends to develop that. There is no diagnostic test for psychosis, but testing is always used to rule out any other medical or substance abuse issues before formulating a firm diagnosis of psychosis. There are some medical conditions that can contribute to psychosis. And because of that, complete blood count, urinalysis, spinal fluid analysis, electrolyte levels, thyroid or liver and or kidney function tests will be performed. Immunological testing and serology testing should be also performed. Urine and blood drug screening tests need to be completed always. In addition to that, we can use CT or MRI to rule out a wide range of organic causes for psychosis. What will be the clinical management? Well, understanding that psychosis is born of both genetic and environmental elements, the primary prevention will target mainly the genetic influence and will be focused on pre-pregnancy genetic counseling. As an alternative, the primary prevention will target also the environment that may influence and that requires a reconsideration of previously discussed environmental risk factors as obstetric complication or maternal health or malnutrition and stress or stable parenting and injury prevention. The focus of the secondary prevention, which is the screening, as it relates to psychosis, involves screening individuals with a family history and monitoring them for subclinical symptoms. A number of evidence-based screening instruments can be used and may aid in diagnosis. Those are Brief Psychiatric Rating Scale, BRPS, the Positive and Negative Syndrome Scale, PANSS, the Minnesota Multiphasic Personality Inventory 2, MMPI-2, and the DSM-5's Level 1 Cross-Cutting Symptoms Measure. The Brief Psychiatric Rating Scale, the BPRS, it's one of the several tools that can help studying people with schizophrenia and related psychotic disorders. They use it to track changes in the symptoms over time. Most probably you won't come across this rating scale unless you're part of a study or a clinical trial for a new type of treatment. The Minnesota Multiphasic Personality Inventory is a psychological test that assesses personality traits and psychopathology, and it is primarily intended to test people who are suspected of having mental health or other clinical issues. The Positive and Negative Syndrome Scale, PANSS, is a medical scale used for measuring symptom severity of patients with schizophrenia. The DSM-5 Level 1 Cross-Cutting Symptom Measure is a self or informant-rated measure that assesses mental health domains that are important across psychiatric diagnosis, and it is intended to help clinicians identifying additional areas of inquiry that may have an impact, and sometimes significant impact, on the individual's treatment and prognosis. In the same area of clinical management, we'll discuss now the collaborative interventions, and those will include the pharmacotherapy. We can use what is called the first generation or the typical antipsychotic. So talking about the first generation, most first generation antipsychotics are no longer considered first tier choices for the treatment of psychosis. However, they are still seen in community-based and forensic settings throughout the country. First generation reduced the transmission of dopamine at the D2 receptor site, a 4-key dopaminergic pathway in the brain. Remember, main mechanism of developing psychosis is an excess of dopamine. So their ability to target the positive symptoms associated with schizophrenia spectrum disorder is obvious. However, they are known for significant side effects, including anticholinergic side effects and high-risk extrapyramidal side effects and sedation that it's known historically to lead to medication adherence problems. We have what is called a second generation antipsychotic, and I will take a moment just to name the first generation. The first generation will include Haldol, Stelazine, and Thorazine. The second generation antipsychotic, those are the drugs that are called atypical and will include clozapine, olanzapine, risperidone, quetiapine, aripiprazole, and they also target the positive symptoms of psychosis with their D2 antagonist. In addition, they target not only the positive symptoms but also the negative symptoms through their 5-HT2A antagonism and, for certain agents, also 5-HT1A. Their tendency to more loosely bind to targeted receptor sites and consequently resulting in lower risks for extrapyramidal symptoms. The second generation antipsychotics are considered now kind of a first-line choice for the treatment of psychosis because they have a lower risk for extrapyramidal syndrome. They have a marked increased risk, however, for metabolic disorders such as dyslipidemia, diabetes, and weight gain, mainly when they are used for long periods of time. Another category of agents that we can use are called anticholinergic agents, and they include cogentin, parlodel, and artane. They are used to treat the extrapyramidal symptoms resulting from antipsychotic medication use. And the extrapyramidal symptoms can occur because of an excessive D2 binding within the nigrostriatal pathways. And this because certain forms of EPS are considered medical emergencies as acute pharyngeal dystonia, and they are potentially permanent as tardive dyskinesia. The anticholinergic agents can be delivered both orally and IM to target those symptoms. We move forward with the clinical management, and we are looking now into the collaborative interventions. What else beside the pharmacologic intervention we can do for this type of clients? So the clinical management of psychosis is subdivided into 4 classifications of elements. Pharmacologic, we just discussed it. Non-pharmacologic, lifestyle modification, and community integration. Although nearly half of those with a schizophrenia spectrum disorder do not receive care, those who do typically do not receive what is called a comprehensive type of care. The National Institute of Mental Health funded the Schizophrenia Patient Outcome Research Team, PORT, P-O-R-T, to develop and disseminate evidence-based recommendations for the correct treatment of schizophrenia. The result of the PORT study recommended an individualized multimodal approach to care involving interventions from all 4 classifications. Just to name a few, the non-pharmacological therapies will include social skills training, family-focused therapy, cognitive behavioral therapy that was already discussed by me, and I was expanding on that when we discussed the anxiety. The same we discussed regarding cognitive enhancement therapy, electroconvulsive therapy, and the lifestyle modification will include serial health monitoring, case management, and vocational therapy. Please take a moment then to observe the interrelated concepts for psychosis and how psychosis relates with all those 6 elements. The health policy is important in the context of regulation that oversee the delivery of mental health care in the United States. The concepts of ethics and healthcare law will definitely relate to ensure the appropriate use of the restriction, treatment, intervention as seclusion or sedation or restraints in this type of patients. In terms of psychiatric commitment, the legal concept of habeas corpus and justification for involuntary treatment must be respected. Communication is a key concept, and this is because it represents an important skill needed to establish the therapeutic relationship with your psychotic patients. Concept of patient education will connect to the instructional treatment of protocol, disease process, and pharmacologic intervention. Last but not least, collaboration is essential for effective treatment and includes the interprofessional team in order to optimize the specialty-related patient outcomes. Please take a moment and look at those exemplars. They will include schizophrenia, major depressive disorder with severe psychotic features, delirium, major neurocognitive disorders, substance medication-induced psychotic disorder. Question 1. Which is the only one of the anxiety problems that present with psychotic features? 1. Panic. 2. Severe anxiety. 3. Post-traumatic stress disorder. Or 4. Substance abuse. Correct answer is 3. Post-traumatic stress disorder. Patients with PTSD, if psychotic, may experience hallucination, illusions, which are false response to and false perception of stimuli, and or dissociative flashbacks. Question number 2. The following is an example of secondary psychosis. 1. Encephalitis. 2. Schizophrenia. 3. Depressive disorder. Or 4. Personality disorder. Correct answer is 1. Encephalitis. Encephalitis represents the best example of an infection medical condition that will lead to psychosis. The other options are all primary causes of psychosis. Question number 3. The DSM-5 currently defines psychosis as having symptoms in 5 different domains. Which of the following is not one of them? 1. Delusions. 2. Disorganized thought. 3. Euphoria with manic behaviors. Or 4. Abnormal motor behaviors. Correct answer is number 3. Euphoria with manic behaviors. The DSM-5 currently defines psychosis as abnormalities in the 5 different symptomatic domains as delusions, hallucinations, disorganized thought, disorganized or abnormal motor behavior, and negative symptoms. The euphoric mood with manic behavior is not one of those categories, and it falls into the category, the concept of mood and affect.